And the topic today is chronic stable angina beyond revascularization. That is a somehow philosophic topic, but let me do it in a practical way. And let me start with the definition of a stable angina. And a stable angina is defined that episodes of chest pain or discomfort that are secondary to myocardial ischemia. And these episodes should not be characterized by unstable clinical characteristics. So they should not be recent onset angina. They should not be progressive or prolonged or unacceptable for the type of life a particular patient wants to perform. And of course, the patient has to be free of heart failure. So stable angina is somehow very easy to define, and about 20% of the patients, or even more, have angina when they are diagnosed of chronic ischemic heart disease. And if you take together angina with the number of patients that present myocardial ischemia, silent myocardial ischemia, and by the way, that is the same thing, episodes of non-controlled ischemia, the number of patients, chronic patients we have with coronary artery disease and myocardial ischemia, ongoing myocardial ischemia, in spite of revascularization and medical treatment, is huge. And we may think that when we see a coronary lesion in one of the epicardial coronary arteries, that we have an opportunity for treating these patients. And that will be certainly the case for a patient with acute chest pain and total occlusion of coronary branch. That is the case of the STEMI, chest pain plus ST cement elevation. That is a clear indication to send the patient straight away to the cath lab. Do not lose time on the emergency department. Do not lose time in the coronary care unit. This patient has to go straight away to the cath lab. But we have other patients in which there is myocardial ischemia, and the coronary lesions cannot be treated with revascularization, not with PCI, not with surgery, because the disease is extended through the coronary tree, and there is no way of treating these patients with revascularization. Of course, when a patient is admitted to a cath lab and you see this type of coronary lesions, chances are that the patient will leave the cath lab with a stent, whatever, here or there or in the more visible place. But it is very difficult to refrain the people that is in the cath lab for not trying to amend something and inserting a stent in a patient, even with this particular coronary tree. And we can go forever, or maybe not. But this example that was published some years ago with a patient that had persistent myocardial ischemia ended up not only with surgery, but also with something like 67 stents, showing that revascularization may not be an easy solution for chronic ischemic heart disease and chronic angina. And one of the reasons is that there is a significant number of patients that present not only angina, but certain myocardial ischemia identified by isotopes or by stress echo or whatever, so it's clear ischemia, and do not present epicardial coronary lesions. That is what we call angina without coronary lesions, X syndrome, and other names. So in the physiopathology of myocardial ischemia, there is a number of physiopathology mechanisms of which probably fixed coronary flow, fixed coronary lesions in the epicardial coronary arteries are the most important component of chronic ischemic heart disease. But we have endothelial dysfunction. We have an increase in oxygen demand. We have thrombi inside the coronary arteries. We have vasospasm, microvascular dysfunction, metabolic dysfunction, and altogether they are responsible for chronic ischemic heart disease and chronic myocardial ischemia and chronic angina. And the proportion of these components is not well known, but let me show you some data from the ischemia trial. That is an ongoing trial comparing revascularization in all patients plus medical treatment against starting with optimal medical treatment. So the randomization is between optimal medical treatment alone or optimal medical treatment plus revascularization. And in the selection of these patients, including in this particular moment in time, there were something like over 6,000 patients included in the trial. And you can see that something like 20% of the patients with myocardial ischemia, chronic angina, and severe ischemia, with more than 10% of the myocardium with ischemia, 20% of this population do not present epicardial coronary stenosis. And 10%, about 10% present left-main disease, which is a clear indication for revascularization. But in most of the cases, what we find is that patients with myocardial ischemia have a lesion in one of the epicardial coronary arteries, or two or three, that are a good target for revascularization. And what we know nowadays from different trials is that in stable patients, that is something completely different from acute coronary syndromes, but in stable patients, the information we have from different trials, the barrier and so on, is that there is not an improvement in prognosis with revascularization on top of medical therapy. And these are the trials. And one of the reasons may be that nowadays we have powerful medical treatments and another ways of dealing with the patients that change the landscape of chronic ischemic heart disease. When we compare nowadays with the era of before statins, aspirin, and all these secondary prevention measurements. And in this particular slide, you can see to your left the number of patients freedom from angina in the CAS trial that was, remember, was revascularization with surgery in patients with chronic ischemic heart disease. You see that as compared with medical treatment, the revascularized patients presented less angina, and this difference was huge. But nowadays, and you see on your right, the data of freedom from angina in the COURAGE trial, you see that there is really a very tiny difference between the number of patients that are free from angina in the revascularization group as compared with the patients in optimal medical treatment alone. And after a year or so, these differences are not significant. And that was true in the whole population, as well as in patients with left anterior descending disease, two-vessel disease, or three-vessel disease. So nowadays, what is going on, probably one of the most important trials in chronic ischemic heart disease nowadays is this ischemia trial that is trying to find out what is the real value of revascularization in patients with chronic ischemic heart disease and myocardial ischemia. The study is going on. The inclusion criteria will be completed by the end of the year, and in one more year time we will have the first results. So what is beyond revascularization, which is not clear if we have to revascularize all patients or not, but what is beyond revascularization is lifestyle and is medical therapy. And we have learned much about lifestyle changes and the impact of these lifestyle changes in not only in the quality of life, but also in the prognosis of patients with chronic ischemic heart disease, and the same with medical therapy. I'm not going into detail with lifestyle changes and opportunities, but just let me show you something. That is the recommendation of the WHO and the World Heart Federation for the prevention of cardiovascular diseases. And it applies also for secondary prevention, of course. And really lifestyle changes, including physical activity, stop smoking, and a healthy diet, has a great impact on the prognosis and the well-being of the patients with chronic ischemic heart disease. And not only that, but these life changes contribute to control of the risk factors. So life changes and controlling risk factors are key in the treatment of patients with chronic ischemic heart disease. Again, just a few samples. One is for the value of stopping smoking. There is not a single trial that didn't show some benefit. You may argue that the patients may have more cancer or chronic diseases, but it is only because the patients live longer. So stopping smoking or banning smoking in public places has a role for the well-being of the population as well as the patients. And I will show you another example of the diet. That is the Lionheart study. That is a study comparing the Mediterranean diet against the sensible lipid-lowering diet in French hospitals already some years ago. And you see that huge differences from the beginning, when the patient, after acute myocardial infarction, was discharged from the hospital in these two arms of the trial, optimal medical diet or Mediterranean diet, you can see that the benefit is absolutely without doubt. And we are maybe not paying so much attention to explaining, well, to begin with, understanding ourselves what we mean by Mediterranean diet and how can we transmit this way of eating to our patients. So that is extremely important, but because there is a benefit out there, and there is a benefit in controlling lipid disorders as well as hypertension, but we are not very proficient about that. That is, again, data from the ischemia trial. That is a quality control that is going on every 2 weeks or something like that. So we are pressed a lot to control the risk factors, including blood pressure. And you can see that there is a significant number, about 30% of the patients in a well-controlled trial that is audited and is, the lead of what we can do with the patients is control. There is still an opportunity for improving the levels of blood pressure, and not to mention LDL cholesterol. In spite of the controls and in spite of the audits, there is something like 50% of the patients that present levels of LDL below or above the recommended levels in the guideline, that is 70 milligrams per deciliter in secondary prevention in the European Society of Cardiology guidelines. So there is still an opportunity here for improvement. But let me move to medical therapy. And with medical therapy, we have two parts. One part is focusing on secondary prevention, and the other part is focusing on the control of myocardial ischemia and the control of symptoms. And again, I'm not going into detail because of the lack of time about the value of secondary prevention measures. The guidelines, the European Society of Cardiology guidelines recommends the use of aspirin and statins in all patients, regardless of any other data. Even if the cholesterol level is adequate, a statin is giving some benefit because of the so-called pleiotropic effects, the anti-inflammatory effects, the impact on endothelial dysfunction or whatever. So the benefit of statins goes beyond the reduction in LDL cholesterol. I put a question mark here for the use of ACE inhibitors and beta blockers in secondary prevention. And that is because things have changed so much that we don't have much data for the benefit of ACE inhibitors and beta blockers in secondary prevention in absence of heart failure or left ventricular dysfunction, or in absence of myocardial ischemia for the case of the beta blockers. So there is a question mark here. There is a lot to discuss. That is challenging. And there is another trial that is challenging the value of beta blockers in secondary prevention, and that will be a difficult one. And not only that, but there is a number, the guidelines were published just a few years ago, and in this very few, I think it was in 4 years ago, now in September, and in only 4 years, we have new kids in the block that may play a role in secondary prevention treatments, medications, in patients with chronic ischemic heart disease. We have revascularization with low doses, the ATLAS study. We have vorapasar with the TRAP2 trial. Vorapasar has been admitted or approved for secondary prevention by the FDA in the United States already. We have ezetimibe that is approved, and we are using ezetimibe as after the results of the improved trial. Maybe the benefit is not tremendous, but it goes with the hypothesis of the lower is better for the cholesterol LDL. We have evolocumab. The recent trial presented just a few months ago implies that, or shows that, the Fourier shows that there is some extra clinical benefit when using evolocumab in the selected patients. And we have new treatments that still have to find a role in the guidelines. For instance, empagliflozin in secondary prevention in patients with chronic ischemic heart disease or in patients with high risk for cardiovascular disease, reduce cardiovascular mortality, and reduce hospitalization, and reduce heart failure. So we have so many new things for secondary prevention that we have the need for update the guidelines on diabetes, the guidelines for secondary prevention in chronic ischemic heart disease. And again, I'm not going into the detail of reviewing all this data, but let me show you a couple of slides with some points that are still under discussion. High dose or low dose statin, and if LDL is a target or it is only just giving a high potency statin. And this slide from a meta-analysis or for an incredible number of patients from the Veterans Administration database, you see that the survival of the patients in secondary prevention is related to the intensity of the statin. So it goes with not only LDL, the lower the better, but the more potent the statin, the better for the patients. And another interesting observation is in this publication that review what happened with discontinuation of statins. Because, I feel a pain in a leg. By the way, a pain in a leg is never an intolerance to statins. The pains in the legs should be symmetric. But for one reason or another, a number of patients stop or discontinue the treatment, or because they feel well and, that I am feeling well, that I'm not going to take so many pills. In all the trials or in all the studies that analyze the outcomes of patients continue the treatment with statins in secondary prevention against the patients that for any reason discontinued the treatment, there was an increasing mortality in all the cases when you discontinue the treatment with statins. So let me move to the medical treatment that focus on controlling myocardial ischemia. The guidelines recommend calcium channel blockers and beta blockers, and then in a second line, ibabradine, log nitrates, and so on. And I think that is very simple, but I don't see the reason why we should start with a calcium channel blockers, where a calcium channel blocker, where they do not produce any benefit in secondary prevention, and we don't have data to know if they can control ischemia nowadays, because the last study with calcium channel blockers was so many years ago. And we have certainly a number of mechanisms that offer an incredible opportunity for using different drugs with different mechanism of action that may contribute or be complementary for controlling myocardial ischemia. We have drugs that act on increasing the oxygen supply or reducing the oxygen demand or reducing myocardial ischemia because of a metabolic effect or because of a reduction in the calcium overload that is triggered by myocardial ischemia. So we have a real incredible number of opportunities with different mechanisms of action, all focusing on the control of ischemia. But in fact, we only have 7 groups of drugs. And we may call it the 7 magnificent, if you remember, with the old people here, there's not many old people, but the mature people will remember this picture, this film that was a classic, Western classic, The Seven Magnificent. There is only one caveat here, and is that all these seven magnificent are dead now. So, but we have nitrates, we have beta blocker, calcium channel blocker, timetacidine, nicorandril, ibabradine, ranolazine, and there is ongoing research. And the problem is that none of these seven magnificents have a role in improving survival in secondary prevention when given without any selection of the cases. So all are very potent anti-ischemic drugs, but for secondary prevention without myocardial ischemia, there is no reason for using these drugs in all the patients in secondary prevention. And by the way, there is more and more and growing information about the safety of the use of a very classic and popular anti-ischemic agent, that is long-acting nitrates in any form. Isosorbate dinitrates, long-acting patches of nitroglycerin. There is a concern because, for whatever the reason, looks like in chronic treatments, there is an increase in mortality in patients taking long-term nitrates. And one of the reasons may be that they are associated with endothelial dysfunction. So nitrates, the effect of nitrates, or the mechanism of action of nitrates, they are nitric oxide donors, but in chronic treatments, looks like they deteriorate endothelial function and may be associated with poorer outcome. And in fact, the European Society of Cardiology guidelines recommend the discontinuation of nitrates for long-term therapy. With beta blockers, we don't have evidence of benefit, but they are very good anti-ischemic agents. Same with the case with calcium channel blockers. With the trimetacidine, we have evidence that there is a benefit to control myocardial ischemia, but there is no benefit in secondary prevention. There is an old trial, the MIP trial, after myocardial infarction with no effect at all on survival or hospitalization. And there is another trial that is focusing on patients that go through a revascularization procedure, and trimetacidine is given as against placebo to see if there is any benefit. There are some side effects that may be of concern, but the study going on is a very important trial, and we will see what happens at the end of the trial. Then we have ibabradine, and ibabradine, as compared with placebo and as compared with other anti-ischemic drugs, have a potential for improving myocardial ischemia, for decreasing the number of episodes of angina, and for increasing the functional capacity of the patients with chronic myocardial ischemia. And this is one of the studies, the associate trial, where you see that as compared with placebo, ibabradine plus atenolol is better than atenolol plus placebo. So that is all patients receiving atenolol and adding ibabradine for a further control of heart rate. There is an increase in total exercise time, limiting the time to angina, and so on. So there is a clinical benefit here in these and other trials. The problem is that in the Signify trial, in patients with chronic ischemic heart disease, if angina was present, there was an unexpected finding, and that is no benefit or maybe some harm in these patients when they receive ibabradine, maybe because of the dose used in this trial in many patients was higher than the recommended dose in the guidelines, or maybe because of the association with calcium channel blockers. We don't know very well, but there is that was unexpected. And then we have ranolazine, and the mechanism of ranolazine is quite peculiar and unique. Ranolazine blocks the late sodium current channels, whatever it is, because it is not a channel, it is a a molecule in the membrane that interacts with something and lets flow the sodium or the calcium. And what happens with the late sodium channels in myocardial ischemia is that they induce an overload of calcium inside the cell. And this overload of calcium inside the cell have an effect on, have an arrhythmic effect, heart failure, and induces more ischemia. So blocking these late sodium channels reduce the calcium overload in the cell and may have an antiarrhythmic effect, may have a beneficial effect in heart failure, and may have a beneficial effect in myocardial ischemia. And by the way, also in diabetic patients. And when the decision had to be made on how to focus for a big clinical trial, outcome trial, the selection was acute coronary syndromes, but we have more information in patients with chronic ischemic heart disease and in patients with chronic angina. And that is one of the trials. There is a number of them, but that is somehow representative. That is the CARISO trial. And in this particular subset of patients, we selected the patients that were receiving the maximum tolerated dose of beta blockers or calcium channel blockers because of the reduction in blood pressure, of the heart rate. So these were patients treated with the maximum tolerated dose of beta blockers, of calcium channel blockers, and adding ranolazine and comparing ranolazine against placebo, you again see that there is an improvement in the functional capacity and a reduction in ischemia. And focusing on this trial after acute coronary syndromes, that was for a number of months, you see that in patients with previous myocardial angina, coronary heart disease, an episode of acute coronary syndromes, but the patients have prior angina, you see that there was a benefit. This is a selected group. That is not a direct clinical trial, but at least the trend is there. And you see that there was differences between the two groups, the group receiving placebo and the group receiving ranolazine, for the composite endpoint of cardiovascular death, myocardial infarction, or recurrent ischemia. And that was not only in patients with prior angina, it was also observed in patients with diabetes mellitus because of a similar mechanism of action. And there was also the same trend in patients with left ventricular dysfunction or high BNP levels. The curves were similar. And when we focus in the normal population, not in population included in clinical trials, there are some sources of information where we can explore in databases or in registries what is the potential benefit of a particular strategy for treatment. And that is one of the examples that comes from a big database that can be accessed, and you can have the data if you pay for the data, and then you can treat the data from with the appropriate statistical methodology to select the patients you want to explore and compare. So you select patients that belong to groups that can be compared. And that is what these people did in this database. And they ended up with 4 groups of patients treated with, there were patients that still presented myocardial ischemia or angina and receive a starting point with another treatment. And that could be a calcium channel blocker, a beta blocker, or ranolazine. And you see that the benefit was as compared with ranolazine as compared with the others, with beta blocker or nitrates or calcium channel blockers. The ranolazine was associated with clinical benefit, with less need for emergency visits or admission to the hospitals. So ranolazine in real life is, and compared with others, even if it is not a direct clinical trial, a randomized trial, there is evidence that ranolazine produces a benefit that is at least as good or even better than the other anti-ischemic agents. So my conclusion could be that the title should be not chronic stable angina, beyond revascularization, but chronic stable angina, medical treatment before revascularization, or at least there is no reason to compete medical treatment with different mechanisms of action with revascularization of the appropriate selected patients. And the last challenge that comes here is how we select the anti-ischemic agents we are going to use in our patients. We can follow the guidelines starting with beta blockers or calcium channel blockers, or even the guidelines, the European Society of Cardiology guidelines accept the possibility that these second-line agents can go first line if there are some contraindication or intolerance for beta blockers or calcium channel blockers. And these are drugs that have a number of contraindications and side effects. And so to select the appropriate anti-ischemic drug for your patient with stable myocardial ischemia, you have to consider the clinical profile of the patient. And maybe there is some patients that are very good candidates for a particular treatment. For instance, patients with heart failure should be treated, if possible, with beta blockers or with ibabradine. Patients with AB block should not be treated with beta blockers because of that is a clear contraindication. But there are, nitrates do not have so many contraindications. Ibabradine do not have almost any contraindication at all and is relatively well tolerated. And so you can select according to the comorbidities and the profile of the patients. You can make your choice for starting the treatment. And one algorithm that can be followed, that is a way of thinking, is starting with the heart rate. So if a patient with chronic ischemia, stable chronic ischemia, has a heart rate that is high, let's say over 60 or over 70, you should start with something that reduces heart rate. That is a principle. That is to decrease oxygen demand. And you can start with a beta blocker or with ranolazine or ibabradine according to the systolic blood pressure. Because you are not going to use a beta blocker or a verapamil or diltiazem in patients with, let's say, low systolic blood pressure. And if the patient has a heart rate that is below 60, beta blockers or calcium channel blockers that reduce heart rate should not be the first selection or the first indication. And again, if systolic blood pressure is low or high, the options will be dihydropyridine or ranolazine as a choice. So we have a number of medical drugs with a different mechanism of action and a different contraindications. And to select the best one for a particular patient, we have to tailor the therapy according to the patient profile and comorbidities. And in conclusion, I think that chronic ischemic heart disease is a huge medical problem, even with the best of the treatments, and it imposes an enormous social and economic burden. Lifestyle changes are really very effective to improve the prognosis and the well-being of the patients and should not be forgotten. Revascularization is an option that probably should be reserved for selected patients in which we cannot control ischemia, but I strongly believe that it should not be a routine for all patients with chronic ischemic heart disease. Let's see what happened with the ischemia trial. And therapies with new mechanisms of action adhere and should be used in everyday clinical practice. Thank you.